Everyone. I would like to thank Dr. Navneet Shah and Dr. Arvind Gupta for the kind introduction. I'd also like to congratulate Dr. Banshi Sabo, Dr. Shank Joshi, Dr. Hardik, Dr. Dhruvi, and all the other organizers for pulling off this wonderful event, so much packed with so many international and national luminaries. I think it's one of the best conferences in recent times, and so my heartiest congratulations. Actually, I was supposed to give one talk later this evening, but yesterday I had a call from Dr. Banshi Sabu saying that Dr. Leaf Group had to pull out due to a health problem, and so he asked me to step in. So I'm more like a Stepney, a poor Stepney for Professor Leaf Group, but I'll try to do my little best that I can do with this topic. So the topic is precision medicine. Is it a reality? Slightly differently worded from what Dr. Leaf Group had said, but the title doesn't matter. I don't have any conflict of interest to declare. All the government agencies have funded all the studies which I'm going to present. So I would like to start at the very beginning and start with a definition of what is personalized medicine. Different people, so people call it precision diabetes, precision medicine, they call it personalized diabetes. But to me, the very simple definition is this: the right treatment for the right patient at the right time. This is personalized medicine at its best. You may say, okay, I understand the right treatment part. The right patient part also I understand, but this right time part I don't understand. How can it change from time to time? Very simple. Today you start treatment for a patient. He has got the prescription with you, and it's actually happened to me. Patient doesn't come back for 15 years saying that I visited Dr. Mohan, he has given me a prescription, what more do I need to do? So I'll continue for 15 years. In that 15 years, his liver has got affected, his kidney, creatinine has gone up, his EGFR has come down, and the prescription that I wrote for him 15 years ago is totally inappropriate. Okay, but he's still continuing it, saying that you only wrote that particular one. I said I wrote it at that time. It is not valid for this time. Your body also changes, and that is why that is true personalization, where you don't follow a textbook, but you actually personalize. And like those questions in the beginning, is it personalized medicine or is it precision medicine? Whatever guidelines or whatever you have, at the end of the day, the patient sitting in front of you is very important. And no guideline can help you regarding that. Now, there is also a slight difference I'd like to make between precision medicine and personalized medicine. Actually, there is no difference, but I'm just trying to make this in a scientific context. Precision medicine, as the name itself suggests, is precision. So what is that precision based on? You can use it for all the knowledge that you have about a particular drug or a group of drugs. You can put in all the clinical features of a patient. There may be something which says EGFR below 45. You cannot give this particular drug. So if you put in all these algorithms into a computer, I'm sure today with today's technology, we're able to do all this technology. It's not great technology for a computer to tell you, I prefer this particular drug for this particular. You're given the age of the patient, and then you're given all the clinical characteristics. And for all that, this seems to be the best drug. So that is precision medicine at its best. But then that is all based on science. There is also a social context to it. The patient doesn't like that drug. You give it to the patient hates it. He says, no, that medicine is giving me some side effect, which you may not even have heard of, but you'll have to respect that. Plus, the patient's preferences, the social context, whether it's affordable or not. The computer may tell you that the GLP-1 receptor analog is the best for this patient. That patient cannot even afford sulfonylurea and metformin. How are you going to give GLP-1 receptor analog? So probably into the algorithm, you'll have to say, patient can't afford, patient can't do this, can't do that. You can refine it. But what I'm trying to say is, even at the end of all that, what you get from a computer or what an algorithm or what artificial intelligence tells you is different from real world. When you're actually sitting with the patient, you have to discuss with the patient. And that's why with telemedicine, with all its advantages that we've had during the lockdown, people say, but I still miss that touch where, talking to you and sitting with you is different from talking on a telephone. So that much is what personalized medicine is all about. Now, where do we apply personalized diabetes? Personalized oncology is very well known. We know that all breast cancers are not the same. You have hormone positive, hormone negative, the spread of the tumor, all kinds of things decide that. In diabetes, what we try to do is, for example, you take type 2 diabetes. We think that type 2 diabetes is one disease. So the guideline says first try metformin, then that's not good. If you have heart disease, you give an SGLT2. If that is not good, then you give something else. Like this, we go on using algorithms derived from large studies, but based not on the individual, but based on groups of people. Now, that may or may not work. And in the case of type 2 diabetes, we already know that response to therapy can be, to some extent, determined even using artificial intelligence. With respect to complications, we know that there are some patients who, after 30 years, 40 years of uncontrolled diabetes, they don't have a single microaneurysm in the eye or no microalbumin. There are others who, in 2 years after diagnosis, they developed all the complications. And you may say, well, he might have had it for 30 years. He's only 17 years old. He got it when he's 15. By 17, he's already developed all the complications. So when did he get it? He couldn't have got it before he was born. So there are definitely certain groups of people who do well and others who don't. And I'll come back to that. Monitoring, it's very important, and I'll show you how personalized medicine. But the most important place is in monogenic diabetes, and I'll talk about two conditions: maturity onset diabetes, the young MODY, and neonatal diabetes, which is newborn diabetes below 6 months of age. Let me tell you that this personalization of treatment for type 2 diabetes is not new. We are only giving it a new name. It's an old wine in a new bottle, so to speak, because we know that for obese people, we would give a different drug. For a very thin patient, we would give a different drug. We're not going to give a GLP-1 receptor unlocked with BMI, with a BMI of 18, So we would like to give insulin to that patient. Age, GFR, very important. For an 85-year-old person, you won't give glibenclamide, obviously, okay? So like this, we are already doing this. And then we say, maybe drug A is better for this patient, drug B for this patient, A plus B for this patient, C for another patient. We're already doing it, but we're doing it mentally, and we're doing it with our clinical experience. Now, I won't go into the pharmacogenomics. It's only a slowly evolving field in the case of type 2 diabetes, but we already have a lot of indicators. For example, we know that these genes, KCNJ11 and ABCC8, are involved in sulfonylureas, and I'll talk about that. Biguanides, we know that the SCLC determines whether you respond to metformin and whether you also get side effects, and so on and so forth. But this is a very rapidly evolving field, but it's still expensive. If for every patient to write a 2 rupees metformin, if you're going to do genetic testing, it is not going to come into public domain until public health, until it becomes really, really cheap. Maybe one day for 50 rupees, we'll have a genetic test. Then we'll probably put it in. This is more for scientific purposes. Now, Leaf Group was supposed to give this talk. That's why I put in a few of his slides. He would have definitely talked about this in his precision medicine because this is his baby. 2 years ago, he came up with a very novel paper in Lancet Diabetes, where he said that all type 2 diabetics are not the same. There are different subgroups of type 2 diabetes. A classic paper which is quoted again and again. Basically, what he said was there are 5 different types of type 2 diabetes. Although the first one I would kind of disagree. This is not really a type 2. This is a severe autoimmune diabetes. At best, you can call it as LADA or type 1. This is not really a type 2 diabetes. But the others are all classical type 2. There's a severe insulin deficient variety, SID. There's a severe insulin resistant variety. So straight away, the beta cell is defective here. Here is insulin resistance is defective. Then there's a mild obesity-like diabetes. They have obesity, but they don't have metabolic syndrome. And then there's an age-related one. After 60, 65 years, if you take Chennai, Delhi, Mumbai, Ahmedabad, almost 50% of people are having diabetes. And another 30% have pre-diabetes. These are mild age-related or marred type of diabetes. Very rarely they'll develop complications in their lifetime. It's important to know this because otherwise, this is not personalization. Then what is personalization? You're going to give every patient metformin. You're going to give every patient the same thing. That you should not do. For insulin deficient patient, you should try to improve the beta cell function. Insulin resistant patient, you should try to reduce insulin resistance by using a sensitizer. So this is what Leaf Group showed. I would like to tell you that just last week, the first paper from India on Indian clustering has been accepted for publication in BMJ Open Diabetes. It should be out in the next 2 or 3 days. I'm hoping it will be out any time, and I'll be happy to share it with you. We have been able to, we left out SAID because SAID is a different disease. I don't believe that it's part of type 2 diabetes at all. But when we did this, we got some slightly different from what Leaf Group had found. 2 of them were the same, 2 of them were slightly different. And I think in the next meeting that we meet, I'll actually show you the results of that and what we got in India. It's a very large study based on almost double the number of patients whom Leaf Group had studied. And that will be the first clustering of Indian diabetes. But I'm not going to show you that today. Now, let me just talk about one more area where personalized medicine has really come to the fore. That is using continuous glucose monitoring. Today, we have sensors like this, the Abbott FreeStyle Libre Pro or the Medtronic's iPro, any of them you can use, and you can get graphs like this. Earlier, we used to get only a snapshot. We'll get one blood sugar, and from there we do on fasting or one post lunch, and then we try to adjust the doses for the whole day. Today, you can see the kind of precision that we have reached. Here is a patient who had an ambulatory glucose profile done. At the time of diagnosis, he had 0% time in target. We can calculate what's called as time in target or time in range, TIR. And on the first day, he had 0%. We're supposed to get it near 100%, at least 70% under target. After treatment, on the 5th day, after taking the medicines I gave him, slowly started responding, 19%, 29%, 60%. By the end of the second week, almost all the sugars are getting under control. Just to see whether it's getting hypoglycemia, I put another AGP, and the second 2 weeks, you can see that there is not one single hypoglycemia, there is not one single hyperglycemia. 98 to 100% of the time is in target. And this is the essence of personalized medicine, that you're able to treat somebody who had blood sugar 300, 400, bring it down smoothly like a pilot would bring it down wonderfully without any hypo, without any hypers. Now let me pass on to, so I would say type 2 diabetes is still evolving, and we will in the years to come get more and more personalized medicine there. But the two areas where the personalized diabetes really come to stay in the diabetic clinic is MODY or maturity onset diabetes of the young, and neonatal diabetes or newborn diabetes. Maturity onset diabetes of the young, or MODY, was first described by Tatchell and Fayance in 1975. At that time, anybody below 40 years was diagnosed to have what we would call as type 1 diabetes. So Tatchell and Fayance said, no, I have many young people who don't need insulin. They've never taken insulin. They're below 25 years of age, but they have no ketosis. They're controlled with tablets. So they coined a term called maturity onset diabetes in the young, or MODY. Later on, the genetics of this was discovered. Today, we know that there are 14 different types of MODY, although in a paper which we just published 2 weeks ago in the Journal of Diabetes and its Complications, we concurred with the Exeter group in UK to show that some of these are really not MODY types at all. For example, MODY 7, MODY 9, some of these MODY 11. These are very doubtful to be MODY types. So we should not even be reporting them. So a new classification of MODY, of only the real known MODY types, is being developed, and I won't go into that. But I just want to talk about the clinical relevance of this. Now, when a 16-year-old girl like this presents, she's thin, severe diabetes, HbA1c is 10.4. 99.9% of all doctors, including endocrinologists, diabetologists, will say this is type 1 diabetes. 16 years old, high sugars, diagnosed, and therefore lifelong insulin 3 times a day, 4 times a day. One such girl came to us, having been told that she has to take lifelong insulin, crying to us saying, is there any way you can do something? One of the things we do first is take a family history. In type 1 diabetes, you might not find a family history at all. Especially in the parents, it will be very unusual, because the child is 16, the parent will be 35 or 40. At that time, diabetes is not so common, so you don't get that. In this particular case, the mother had, this is a girl, the mother had it, and so many people on her mother's side had diabetes. So we said, going through 3 generations of transmission, just like Tatchell and Fayance said. So the next thing we did was we did the C-peptide assay to see whether she's type 1 or not. To our surprise, we found that she had good C-peptide reserve. Then we did the GAR antibodies, came negative. Then we did the zinc transporter antibodies, came negative. So we said, what is this? She's having 3-generation transmission, her insulin reserve is good, antibodies are negative. Can this be something other than type 1 diabetes? Can it be MODY? So we did the MODY genetic testing, and we found that she had MODY 3. This is a HNF1 alpha, this is the arginine to histidine mutation occurring there. And the same mutation, by the time a sister developed diabetes, she also had the same mutation. Mother had it. Every diabetic shown in red on the mother's side had the mutation. Father's side, there were a few, but they're all married into the family. Nobody had any mutation there. So it is very clear that this child had MODY 3, which luckily responds to sulfonylurea agents. So we took her off insulin. We put her on glibenclamide because it's the most tested sulfonylurea in MODY, but we also now use glycoside. We found an excellent response. A1C came down to 6.8. This happened about 10 or 15 years ago. She and her sister are still responding to sulfonylurea. If we had not done this genetic testing, she would have been still on insulin 3 times a day, 4 times a day. So MODY genetic testing helped to avoid unnecessary lifelong insulin therapy in this patient. And this is a classic example of personalized or precision medicine. Now let me end with the last type of diabetes, which is neonatal diabetes. Neonatal diabetes is diabetes diagnosed within the first 6 months of life. Child is born, within 6 months you have diabetes. It is very, very unlikely that the child has type 1 diabetes. Remember that. After 6 months, type 1 can come. Of course, very rarely, even at 3 months, 4 months, you can come. I've got 1 or 2 cases even at 3 months. Although Andrew Hattie says it can never occur. There's no never in medicine, but it's very unlikely, and it definitely mandates doing genetic testing. There are two types: a transient variety of neonatal TNDM, which will disappear within the first few weeks itself, but there's a permanent one which stays. And usually, people treat this child with insulin unless you do the genetic testing. Now, we had the first series published in 2012 itself. We had published the first series of neonatal diabetics, 33 cases. Now we have very much larger series where we are able to find mutations, as you can see here, in the KCNJ11 and the ABCC8 mutation. Now, these two, the KCNJ11 and the ABCC8, if you have these mutations, they will respond to sulfonylurea, any sulfonylurea. Okay. So what we did was, after finding these mutations, we stopped the insulin, started sulfonylurea, and you can see the huge drop in HbA1c which has occurred, and the blood sugars also have dropped. So these children, for these children, it was a miracle, and that's why it makes newspaper headlines saying that neonatal diabetes can be cured. After this, we have become a referral center of ICMR, and today we have a very large series. In fact, we set up what's called as the National Monogenic Diabetes Study Group of India, and you can visit our website, monogenicdiabetes.in. Many of you are already collaborators, and those of you who are not, please send it to us. If you have neonatal diabetes, we'll do it free of cost for you, without doing any charge. We'll do the genetic testing for you. We have also set up the Study Group of India. We're doing a big national study of MODY in India. This is just a partial list of some of the people who have already joined this collaboration and who are in. Dr. Banshi Sabu is right there. We have Dr. Shashank Joshi here, and we have many other people who have actually joined this particular group, and I invite others also to join. As you can see, it's a national representation. The samples come to Chennai, and then we do the analysis of MODY. If you're part of this particular research, we'll do the MODY genetic testing also free for you. Today's our statistics is, out of 1,377 cases referred to us, almost 1,000 cases we have had the clinical phenotype of MODY, and all these genes we have found out. We have close to 250 cases of neonatal diabetes. We have other genetic syndromes which come in neonatal diabetes, about 40. And then we have quite a large series of congenital hypoglycemia, which is the opposite of neonatal diabetes. We have the opposite gene, a gain of function versus loss of function. Then you'll get hypoglycemia at birth. Many of these children have actually to undergo a pancreatectomy if they are not successfully treated with diazoxide. Now, last two slides. When to order monogenic diabetes testing? In all children below 6 months of age, it is mandatory today. Anyone below 6 months of age, please send for genetic testing. All suspected type 1 diabetes, like that 16-year-old girl, but if C-peptide is present, if antibodies are negative, consider that they could have MODY, especially their family history. Now, if you also think it's type 2 diabetes, but they're lean, there's no acanthosin nigricans, then again, it could be MODY type diabetes. So my last slide is that precision medicine is slowly becoming a reality in the field of diabetes. Currently, it's applied to the diabetes clinic for diagnosis of continuous glucose monitoring, and in the diagnosis and management of monogenic forms of diabetes, MODY and neonatal. I told you there are other forms like MID and so on, which I didn't go into. In type 2 diabetes, precision medicine is slowly evolving, and next week when we release the results of our clustering, you can see how in India the clustering varies so much from what is reported in the West, and therefore it is a field which is evolving in the field of type 1. I would go as far as to say that in type 1 also, diabetes also, we are seeing that there is clustering of cases, and not everyone with type 1 is the same, and that is our next field of work. So I will stop here. I'll stop the share now, and then if there are any questions, I would be happy to take.